welcoming Dr. Skand Shekhar, who's also a North Carolinian, and he joins us from the National Institute of Environmental Health Sciences at the National Institute for Health.
Okay, I'm just going to try and see if this advances. Okay, so at least we have a pointer, but it doesn't advance. Okay. Okay. Good morning, everyone. I'm an endocrinologist, and today what I wanted to talk to you all about is a little bit different from what you have sort of heard so far, but still quite related, because a lot of things that we treat as endocrinologists overlap with a lot of things that you experience as patients. And so the title of my talk is aptly Hormonal Woes, Finding the Right Balance. So before we actually get started, I wanted to get a sense of what your familiarity with this issue is. And so I wanted to get a sense from the audience, how many of you have actually heard of or know about endocrine disorders? Could I just get a raise of hands? Wow. Okay, so that's about, I would say, maybe 75% of people in the audience. So it's obviously something that we need to talk more about. And the next question, which is sort of related, is how many of you know someone who has an endocrine disorder or a hormonal imbalance? Again, a fair number of you. Okay. My next question to maybe stimulate your minds is, in Erdheim-Chester disease, what percentage of patients do you guys think have endocrine disorders? Any hands up for 30%? 50%? 80%? Okay, so quite a few. 90%? Greater than 90%? Okay, so 3 or 4. Okay, excellent. And so the correct answer is actually greater than 90%. And this is not me, using my anecdotal experience, but this is data published by the French cohort. Dr. Hirosh is here. And also our experience at the NIH, where we found that those who were tested for endocrine disorders in a systematic fashion, 90% of them have some form of deficiency at some point in their life. So, clearly there is a lot we need to really think about. So going back to the basics of what the endocrine system is, hormones are essentially chemical messengers, and what they really do is they facilitate a lot of your day-to-day and long-term functions, such as being able to take food in and process it, such as regulating reproductive functions, energy, stress. A lot of these things are mediated by hormones, and endocrine glands, really what they do is they secrete these chemical messengers that enter the bloodstream. And here what I have on the slide are a number of organs that get affected, unfortunately, by histiocytosis. So in the previous talk, you heard about how you should see an endocrinologist because pituitary involvement is fairly common, and I would like to echo that, because hypothalamus and pituitary glands sit in the brain, and they really are the conductors of the orchestra that is the endocrine system. You also have the thyroid gland, the adrenal gland, and some of the other reproductive glands that are involved in hormonal functions. So this is just a slide kind of reminding ourselves about what this disease is. I don't think anyone needs a reminder, but nevertheless, we know that this disease has been described as far back as 1930, and it is obviously a histiocytic infiltration of various organs, and it affects almost every organ system. I don't think there is any organ system that is spared. And along the same lines, hormone dysfunction has been reported in 90%, greater than 90% of those who have a comprehensive evaluation. So this is quite startling. And I think it really is also an area of improvement for us as a community. What you see here on the slide are various organ systems that get involved, which have been really discussed earlier this morning. These are data that were published a few years ago, and Dr. Goyal, who spearheaded this publication, reviewed the previous publication from our group at NIH. And what they found was that some of the most common disorders that you see in ECD are actually hormonal disorders. And I would go on to say that this is still an underrepresentation because our understanding is still fairly limited. And the more we understand this disease, the more we uncover some of these issues. So without wasting much time, I think we'll jump into what I consider the 6 cardinal principles of managing endocrine disorders. The first of them are that obviously it's one of the most common condition that you will see in ECD. And this goes whether you get molecular therapy or you do not. Endocrine disorders are unfortunately going to be part of the spectrum. And for that reason, everyone should undergo annual hormonal testing, because regardless of you being treated, these disorders unfortunately can develop during the course of the disease and can persist even after remission. The third point, I think, is also an important point. And I know that what the ECD consensus criteria says is really the MRI of the brain, but pituitary is part of the brain. And so pituitary gland should also be focused at, and we had a discussion yesterday with some of my colleagues, and it's something that needs to be thought about. The most important thing, I think, if you guys think about, is that I would like you to take away this important message that unfortunately hormone disorders can persist and they do not go away. Unfortunately, this is one of the irreversible conditions that you see in Erdheim-Chester disease. And the good news is that they are very manageable, but they do require you to be friends with an endocrinologist, and that might be a lifelong buddy. And finally, I think early referral to appropriate specialists is important. So whether you're hematologists or you're neurologists or any other specialty, I think we need to work together as a team. And the importance of multidisciplinary team was shown earlier by a lot of presenters, and I thank them for that. And I think the last and the most important point is that I think the keystone of really these disorders is your involvement as patients, you being educated, you being partners as other diseases. You all have to partner in this condition. So moving on to some of the specific endocrine disorders that you see in ECD. Many of you in the audience might have experienced this disorder. It used to be known as central diabetes insipidus. A bunch of very, very smart people got together and they decided to change the name to arginine vasopressin deficiency, because it's actually this hormone that is deficient. And the reason they did that was because this disorder has nothing to do with diabetes that you hear about in advertisements and from your family members. That type of diabetes has elevated blood glucoses, but this doesn't actually. And what really I mentioned earlier was that the deficiency of this hormone really messes up with the water balance of the body. What is also important to note is that 1 in every 3 patients, and probably more, will have this disease as years go by. And in many cases, this will be associated with abnormal findings if you look at their brain scans. But I just want to again caveat that by saying that a normal pituitary scan does not mean that you do not have TI. So it's kind of something that you should just be aware of. And finally, it really unfortunately persists and can require lifelong therapy, as we talked about earlier. So what are some of the cardinal principles of management of this condition? It's very important to recognize this as patients, as caregivers, as physicians. If you start experiencing excessive amounts of thirst, you have to wake up in the middle of the night to pass urine, you start getting dehydrated, it's time to go and see someone who knows how to treat this disorder. And it's a simple battery of blood tests or urine tests that can actually detect this condition. Moreover, you can get a brain scan that might show abnormalities. So there are certain things that you do anyway, and this can be picked up on those things. Fortunately, unlike ECD, there are good treatment options for this specific disorder. But again, the cardinal principle is you being aware of these treatment options. There are tablets that you can take once or twice a day that can actually really, I'm sure some of you might be on them already, There are nasal sprays, and then there are also parenteral or IV or subcutaneous injections that you can use to treat this condition. So there is hope, but you just have to work closely with a specialist. Uh, the other, one of the other important disorders that you see in this condition is a disorder called adrenal insufficiency. And it is really a deficiency of cortisol and aldosterone, both of which are secreted by the adrenal gland. Cortisol is also known as the stress hormone, and it maintains a host of functions, including blood pressure, whereas aldosterone also contributes to blood pressure maintenance, as well as a water and sodium balance. So they have very critical roles. And as has been shown by multiple studies, adrenal gland involvement is fairly common. And whether you pick it up on imaging or you do blood tests, it continues to be a major challenge. Another important finding that our group had reported a few years ago was that BRAF V600 pathogenic variants have a 6-time higher risk of adrenal involvement. So it's just important to keep in mind. And then I think finally, sometimes it's inevitable to use steroids, and you have to do them for reasons that are beyond our control. But one of the downsides of doing that is that you end up developing what you call secondary adrenal insufficiency. So just like diabetes insipidus, some of these symptoms are a little bit non-specific, but I want to again highlight fatigue, as has been highlighted by some speakers earlier. Weight changes, nausea, abdominal pain, skin pigment changes, low blood pressure, sleep problems, mood problems. All of these things can be really a manifestation of AI. And if you are on steroids for a long period of time, you can see the opposite. So you'll have a high blood pressure, you'll have weight gain, you might develop the regular type of diabetes. Good news is, again, you can pick it up and you can do some basic set of labs, and then you can follow them up with more sophisticated testing. And you can also see some changes on various scans that your doctors might order. And just like DI, the good news is that there are good treatment options available, but the most important element is patient education and you being aware of these conditions, so you can seek out the help that you really need. The most common form of replacement is a drug called hydrocortisone that you can be on, and over a period of time, if you're on the right dose, it really won't hurt you. It in fact will help you feel better. In case you require it, sometimes you need to also keep handy a dose of emergency hydrocortisone injection. And I just want to point out that this is a very important thing to keep in mind, because some of our patients will develop nausea. They may not be able to eat for days. They may not be able to, do a lot of other tasks. In that situation, you really do need to get some steroids in your system. So always, keep handy an injection of hydrocortisone, and always carry a medical error bracelet indicating that you have adrenal insufficiency. It might be a lifesaver. Okay, so moving on to some of the sexual hormones that are deficient. In men, you can find testosterone levels being really low, and in women, it's estrogen. And it is fairly common in patients with ECD, and this has been, again, shown by a number of studies that hypogonadism is amongst the most common manifestations. It could be due to testicular infiltration, or it could be due to involvement of the pituitary gland, and in women, it's obviously ovarian involvement. And so, again, the point I'm trying to make is that it's multifactorial and needs to be screened for. There is another hormone called prolactin that can actually go up, especially if you have a high burden of histiocytic infiltration in your CNS. And that can also worsen hypogonadism. If you have been on long-term steroids for whatever reason, that can directly suppress the secretion of testosterone and estrogen in men and women respectively. So again, the disease itself, some of the treatments, they can all contribute to this condition. And just like some of the other conditions we talked about, there is a large number of symptoms that you can see, ranging from low libido, fatigue, loss of muscle mass, depression, mood swings, sleep changes, infertility. You can have reduced shaving frequency. You can lose hair in your armpits and in your groin. I mean, there are lots of conditions that can be harbingers of this specific side effect. And again, the good news is that it can be picked up on a blood test, and it can also be picked up on some imaging that your doctors might order for you. And again, the most important thing is for you to be aware of this condition. seek help and for physicians who are treating you to discuss, because there are sometimes there will be a risk benefit analysis because testosterone replacement can have its own downsides. So you always want to discuss the risks and benefits and then take a decision appropriately. Fortunately, we have a host of options to treat hypogonadism. They include injectable testosterone, they include gels, they include tablets now that can be popped in once or twice a day. And they can really restore your testosterone levels quite nicely. In women, you can use patches or you can use pills. Again, they work beautifully and you have a huge benefit of replacing these hormones. The other important point to keep in mind is, just like some of the other conditions we talked about, regular monitoring is very important. Hemoglobin, PSA, all those types of things have to be monitored. So it's good to work with someone who knows what they're doing. Another important condition that you can see is hypothyroidism, which again is due to lack of thyroid hormones. And just like some of the other conditions, it's the symptoms are fairly non-specific. It can affect up to 28% of patients. And in fact, we reported this in a journal publication a few years ago, that there's a very high burden of hypothyroidism in ECD. It is due to both the effect of histiocytosis on your thyroid gland, which is this butterfly-shaped gland that you can see, or it is due to your pituitary disease that can actually precipitate this. There are certain treatments also that can actually contribute, including steroids and interferon therapy that can aggravate or precipitate hypothyroidism. I think the point here is that you really need to think about reversible causes of fatigue, and hypothyroidism is one of them. Weight changes, mental fogginess, hair changes, blood pressure, cholesterol problems, quality of life not being appropriate. I think these are all important markers of disease. And good news is, again, you can pick this up on lab tests, blood tests. You can pick this up on imaging. And the good news here is that replacement of thyroid hormones is one of the most simple things that you can do, and it can make a huge impact. The risks are fairly low, and it's actually a physiological. It's almost like a supplement. The only caveat is that you have to, be monitored to make sure that your levels are appropriate. Moving on to the last section of my talk, there are other disorders that you can see which have not been as extensively reported. I know that they do exist. Things like the metabolic syndrome and diabetes mellitus, which is your glucose diabetes, that can be worsened due to the disease, and it needs to be, again, screened for. Further, there is a hormone called growth hormone that usually kids require to grow, but even adults, it really makes you feel well, maintains your bone density, maintains your muscle strength and mass. Unfortunately, growth hormone levels cannot be easily replaced sometimes, and so it has to be, again, a discussion with your provider. And finally, as you all know, bone disease is fairly common, but osteoporosis is really referring to fragility of your bone, its weakness. And this, unfortunately, tends also to be common in all malignancies. And so, it's important to get screened for it, at least have a discussion, take vitamin D, take calcium, make sure you exercise, and try to, keep those levels in range. And so I think that's really important that, you have that discussion with your physician. This was a table that I borrowed from the ECD consensus guidelines that were published about 3 years ago now, as they pertain to endocrine conditions. And as you will see, central diabetes insipidus is part of the criteria in conjunction with other clinical and biochemical criteria to make the diagnosis. So in fact, central DI, or the newly coined term AVP deficiency, can actually be the first marker of disease, and that's how important it is in the spectrum of disease. MRI is, again, recommended in all patients. Lab studies to screen for hormonal dysfunction are recommended in all patients on an annual basis. So just because you had one which was normal doesn't mean that it'll always be normal. Steroids sometimes are needed. They're not recommended, but they can also contribute to some of these disorders. And once you have sort of gotten your first set of labs done and imaging done, it's important to also continue to serially screen for these with both imaging as well as biochemical tests. Finally, I just want to highlight this in red. Endocrinopathies can persist or can develop despite treatment of ECD, and therefore annual endocrine evaluation is recommended. And so this is, I think, the most important thing that if you want to take one thing away from this talk, I think this is the most important thing. Here is a set of resources that you could use. So I'm not going to go in too much detail. You can take a picture of this and you can look at them at your own time and certainly find some resources to help you out. I know I've maybe gone over a little bit, but I hope this was helpful and thank you for your time.
One or two questions. Okay.
Thank
See
you.
you at lunchtime. Thank you so much.